we do have a time-sensitive thing that's going to be coming on very shortly from Dr. Winslow from Suffolk County. He's going to talk about their RSI program, how they got it off the ground, what it entails, the steps they took, and how they've made it successful, just because we don't have someone else in the region that's done it before. So luckily, Dr. Winslow was kind enough to be willing to come on with us. But he's time sensitive, so we're probably going to let him go first before everything else, and then we'll take care of the roll call, everything else after that.
I can wait 5 minutes if you want, as long as I'm off by like 1:20.
Okay, that works. Thank you very much for joining us.
Rick, I saw you heard you were talking about that silo case. Do you know, was there any kind of debriefing or done with the people that were involved?
We have in-house debriefers, and yes, there was.
Okay, good, because I definitely talked to a couple people that were semi-involved that definitely struggled with that case. That sounds.
No, we have an in-house team that goes around and does that, and they were activated immediately.
What about I know within your agency, but what about like EMTs, firefighters that were on scene?
I can't speak to that. I know usually our team reaches out to the fire department, but I can't tell you if they did or not. So.
Okay.
I mean, I can find out from, I would think that it would be Elmira Heights.
It was Elmira Heights.
I can find out from, I can text Jason. He's in that group there, and he can tell me whether they got people, if you really want to know. Was that a death at the scene?
Yeah, he died. He died.
So you couldn't even get him out. How did they finally get him out?
I think they emptied the silo and get him out.
So he probably was suffocated.
Yeah.
Our fire department was there too, weren't they?
Yeah,
I saw them pull in.
Yeah, they came with their rope rescue team, but I think it was too late by the time they arrived there. He was already under.
So they weren't involved in.
As far as I know, they were not involved, and they were probably involved in the extrication, but not involved beforehand. I mean, the only reason we were on scene so quick is because it's 100 yards from our headquarters station. So
Did you drive or walk?
yeah. So you know, but
Rob, do you have my slides that I had sent that you can share, or do you want me to do it?
If you could share it, I'm trying to work out between two computers right now, and it's not working so
I'll see if
well.
yeah, hold on. Hold on. I should be able to do it. Let's identify it.
If not, have them here, I could share for you.
I have 3 screens, so can you see that? I have to move it. Hold on. I can get it to fit. Trying to get it to fit. Hold on.
Take your time.
Can you see that?
Not yet.
You see it now?
No.
Hold up, I can go ahead and share it here so everyone can see it.
Okay, yeah, please do. I had sent it electronically yesterday because I knew this would happen.
Yeah, we like redundancy because this always seems to happen.
Perfect. That's all I need. I'm ready when you are.
All right, we'll turn it over to Dr. Winslow. He's been kind enough to speak to us on the Suffolk County EMS RSI program. Since it's something that our region keeps, flirting with a little bit, it'd be good to hear from somewhere that they've been able to get it off the ground and do it successfully. I'll turn it over to Dr. Winslow now.
Thanks. I really only need 5 minutes, but I thought I would start with just, this is the same presentation I gave at the CMAC in November and had emailed to numerous physicians in the area and other interested parties. While I'm reviewing it, just please ask or think about the questions you want to ask. I can say that we've had 10 years of an experience in growth here, and so some of it is apparent in the slides, but if there's something that I left out or you had a specific question, just ask me. I don't have to leave until 1:30. So for those of you who don't know me, I'm an emergency room physician. I'm also the regional EMS system medical director for Suffolk County. I also have a bunch of other hats that I've been wearing through COVID. Next slide. Or can I do that? Oh, perfect. This is the protocol in its most recent version. As you'll notice, it's gone through several generations going back. It was a pilot program for 3 years from 2009, and then became a part of our protocol off pilot in place in 2012. And several generations later, this is the most recent version. I'm not going to bore you with the details, but it is slightly different than the collaboratives. And I'll get to that in a slide later, but just realize that some of the things that are in here are, this is for a solo paramedic under certain circumstances. And we didn't start that way. We started as it being a 2 paramedic skill, both who had to be RSI credentialed to use it. We then found that the medics that were very skilled like to have another ALS provider on hand, but not necessarily an RSI credentialed medic. You'll also notice that we have use of an automatic transport ventilator if the agency wishes to purchase, train, and equip their members, which frees up your hands. We have the use of lidocaine as a pre-sedation agent for neuro cases that was brought in by our neuro personnel after they looked at our RSI did not have lidocaine for those with raised intracranial pressure. And so they liked that. Sorry, fentanyl, not lidocaine. And you'll also notice that we use either Versed or etominate as your induction agent, and either succinylcholine or rocuronium as the paralytic. But it is also not used in pediatrics. Next slide, please. So it began in a pilot program, and we only had 3 agencies when it started. We had 3 involved agency medical directors and 5 paramedics go through the original credentialing, obtained all the medications and equipment. We then trained them in the procedure and followed it very closely. It started very slow. I think the first year we only had a total of 10 cases that were performed. What began as a 2 ALS provider skill now can be done as 1 RSI medic, as long as they felt comfortable doing it on their own. It began with etominate and sucks as the only choices, and now we've added ketamine and rocuronium as alternate choices, and we've added fentanyl for pretreatment consideration in selected patients. We then, in I think 2015, added high flow nasal cannula apneic oxygenation after several of the airway studies in critical care and emergency medicine noted its use. Was an added benefit for preventing a drop in pulse oximetry and whole body PaO2. We added the use of an automated transport ventilator. After about 8 years, 2 agencies found that they really wanted to try this, and it worked out great. And now we have, I think, of the 26 RSI agencies, about half of them went with a ventilator. Currently, we have 26 agencies and 150 credentialed RSI paramedics. For scope, there's 104 EMS agencies in Suffolk County that respond to 911 calls. We have an annual call volume of 155,000 calls. There are a total of 720 credentialed EMT paramedics in the county. So 150 out of 720 is a pretty robust number. RSI agencies are approved by the Suffolk County REMAC. So the physician representatives of all of the 11 area hospitals, as well as 15 other physician members at large, many of whom serve as agency RSI medical directors, are in REMAC, and they approve the agencies to move forward. EMS agencies are required to have proper training and education, proper equipment. About 2017, we added a requirement for video laryngoscopy. We're vendor neutral, so either of the King Vision, McGrath, those are the majority of the cases of the agencies using those two specific video laryngoscopes. But we found that it was useful for the provider to have that originally as a backup, and then each agency can then decide what they want to do. Many agencies require it for first pass that they use the video laryngoscope. Many agencies also require the use of a bougie. We didn't put it in the protocol. There are things that each agency can decide with its agency medical director and its RSI medics. The Rsi Medic Credentialing is done through the Rsi Subcommittee. So the Rsi Subcommittee is made up of physicians and paramedics who are RSI medics and leaders in education. And a RSI medic may have credentials in several agencies, so it made sense to put the Rsi Paramedic Credentialing through the Rsi Subcommittee. We require a minimum of 3 years of quality field medical care in the 911 system as an EMT paramedic, which means that you had to have a sign off by your agency medical director that you were a medic in good standing, as well as having no serious protocol violations or any problems for 3 years. We also require 10 successful documented field endotracheal tube intubations in the system. We don't want to stop that. We had actually had some medics try to challenge it, saying that, you know, we only have 8, is that enough? And we really feel that those numbers are pretty hard and fast. We originally used 5 years of quality field medical care and 25 successful tubes, and that number was too hard to reach. So the 3 and 10 number was a compromise, and we're not going any lower. The Rsi Paramedic Credentialing is done so that an Rsi paramedic may be called upon as a resource for mutual aid in neighboring districts. We didn't want it to be that an Rsi medic that was credentialed in one small township would not respond to the neighboring agency. So it's a county credentialing to foster good mutual aid response for this skill, because obviously it's not one that each medic in the county may have, and they may not be available at that hour of the day. We require annual skills verification training with a high fidelity mannequin, successful performance of the Rsi procedure in person. We have 7 standardized patient scenarios. It involves the agency medical director. It also involves the agency Rsi leadership. We also have a written exam that's periodically reviewed and updated. It's only 25 questions, but they're tricky. And you actually have to score an 80 is actually very difficult. We actually have several providers that have to take it several times because some of the questions are very challenging, but passage every year is required. We also involve the agency medical director, and we involved myself as the regional EMS system medical director and the Suffolk County Chief of EMS education and training for the entire county. That's a second level to kind of monitor and supervise the system. You can skip to the next slide. So the Rsi Subcommittee was an ad hoc subcommittee of the REMAC. It has both physician and paramedic members alike. It involves myself, it involves Suffolk County EMS division staff. It also involves our air medical branch. So we are kind of unique in that we have linked ground and air over the last 10 years to be under the same protocol and under the same umbrella, and which is really a great thing for our region. We use Stony Brook Emergency Room University Hospital as the base station for not only our medical control, but also for our aviation, and their physicians are involved as well. And their chief of education and training is paramedic Sean Edouard. He's the EMS assistant director. He also is involved in the process, and linking ground and air really made it a great thing for the county, because we didn't want to have 2 different protocols. We didn't want to have 2 different systems working simultaneously. We meet every month, every other month, and we discuss every RSI case in the county to identify any issues related to either the policy in the county or the protocol in the program. We then bring the information back to the entire REMAC at each REMAC meeting. Currently, Dr. Sandy Glantz serves as the Rsi Subcommittee Chair. Shout out to Sandy. He's been involved with the process for as long as I have, going back 12 years. Next slide. So here's the data. So we've done more than 500 total RSIs in the 10 years since its inception. It averages now 80 to 90 cases per year. As of November, I didn't update the slide after CMAC. Forgive me, I've been busy with holidays and COVID. There were 55 up until the November CMAC meeting, October CMAC meeting. In 2020, there were 90 total cases, 68 by ground and 22 by Stony Brook University Air Medical. The success rate is quite good. There were 82 successful endotracheal tube placement. There were 7 cases where an endotracheal tube wasn't passed, but a supraglottic airway was. And there was 1 case of an unsuccessful procedure out of these 90 cases. It was a patient that actually had a complete airway obstruction from impacted food. The patient was unable to be intubated in the emergency room either by the ER physician and the anesthesiologist as well, because the entire trachea was packed with turkey. So we didn't feel that that was a unsuccessful procedure. It was more of an untoward event that really shouldn't have happened to anyone, but it did. In that case, the patient had to be bagged and brought to the hospital. The patient did actually, this one outcome did actually survive the incident, which was interesting, and never having been intubated. Eventually, they were able to use a bronchoscope to remove the impacted food bolus, and then the patient began to respirate on their own and did fine. It's quite an interesting case. So therefore, the overall success rate was 99%, 89 out of 90 procedures with 1 failure. The overall success rate of endotracheal tube passage was 91%, which is 82 out of 90. There were no missed esophageal intubations. In fact, we have not had a missed esophageal intubation in several years. 60% of the cases were used etomidate as the sedative and 40% used ketamine for the induction agent. 90% of the cases used succinylcholine and 10% used rocuronium as the medication choice for the paralytic. Next slide, thank you. The quality improvement process is a 5-step process. It's kind of complicated, but we did it on purpose this way to involve the local agency medical director from the very first day that the procedure is performed. So the first step is the post-call notification to Suffolk County Medical Control flags the call in the system that an RSI was performed. That puts it on our radar to look for the next step. Step 2 is the audit form. It's signed by the ER physician at the receiving hospital documenting where your tube was. Was it in the esophagus? Was it in the trachea? Did you use a supraglottic airway? Did you use an endotracheal tube? And it is signed by the ER physician, and they have to document trachea versus esophageal placement and sign it. This also is a key teaching moment. Say your tube is misplaced and unrecognized. That's the time for the ER physician that's signing the form to step in, to discuss right then and there, hey, this is what happened. Let's discuss the issue. Was there some problem? Was there a mechanical issue? What was the problem? Did you have a video laryngoscope? Did you not use it? Did you not use a bougie? So that teaching right there for each case is very important, as well as if everything goes great. Hey, this was a great case. Let me share this with you and give you a number, and I'll give you follow-up on the case. So involving the ER physician, regardless of whether that ER physician is the agency medical director or not, is the key first step for that medic. This is the Rsi Audit Form. It not only has the indications for the procedure, was it decreased LOC, was it that someone was hypoxic, it also lists what the pre-intubation pulse ox and end-tidal CO2 readings were, as well as the post. It also goes over the moans and the lemons, and it gives you the medications that were used and the milligrams. There's actually a great summary for them to do. So when they go and write their PCR afterwards, they have all the information at their fingertips. It also makes it easy for me to see exactly what transpired. It also has the weight of the patient, age, height, in case you're going to be using a King Airways or rescue device. There we go. This is the second page on the reverse of this document, which is on our website and can be easily downloaded by any paramedic. They literally download, print, and then fill it out. Many of them just keep a copy or two. So step 3, after the procedure, after the patient's delivered to the ER, after the ER physician signs their form, they then call their agency medical director within 24 to 48 hours to discuss how it went. And that's key. I was the agency medical director for 10 years for several RSI agencies, and it allows the medical director to feel comfortable in knowing that paramedic, especially with such a skill. Step 4 is formal peer review. This is done later. So within 7 to 10 days, we require that the agency perform its own peer review. And we've actually teamed up agencies that do very few with agencies that do a lot to kind of let them share. And so they can have peer review done by their peers. Another RSI medic in another area of the county looks at their chart and says, this is a good job, this is points for improvement. It is then brought to the EMS division here, and both the Chief of Education and Training, Chief Masterton, and myself as a regional EMS medical director stand in here and review. Not only did they do steps 1, 2, and 3, but we also reviewed the procedure was done correctly and there were no mishaps. And step 5, we bring every case back to the RSI subcommittee. We've observed there are 3 clinical situations when RSI has been done in more than 90% of the cases. It's one of these 3 almost every time. First would be your head injured or multi-system injured trauma patient. They may have decreased mental status, respiratory compromise with or without a clenched jaw. The exact case RSI was created for. 2, this one is impending respiratory failure from either CHF or COPD. Many of them are elderly. And many of these patients are not GCS less than 8. They're GCS 13, 14, kind of like about to go down, a little groggy, but it's still awake. And if you wait for their GCS to drop, you miss the chance to catch them before they get hypoxic. And that's one of the major issues I have with the collaborative protocol is that they have a requirement of a GCS less than 8, which I think should be removed. We'll get to that later. I have a slide about it. And the third category is that broad spectrum altered mental status with loss of airway protection. It's usually an overdose or a stroke or septic patient that just loses their airway from mental status reasons. Pediatric RSI. There have only been 2 instances of pediatric RSI in the last 5 years. Both were done by our flight medics. Both were done with online medical control because the medics do not feel comfortable intubating very small children, not only in terms of choice of medications and weights and dosages, but in choice of equipment, size of laryngoscope. We don't have a pediatric video that fits. So a lot of that happens to be the medic's choice. We define pediatrics in our county less than 36 kilograms of weight and less than 15 years of age. We only allow pediatric RSI as a medical control option. We believe that online medical control physician presence to discuss the case in real time is important, and therefore agencies are not required to supply every area with pediatric sized equipment unless they wish to do so. It also means that RSI paramedics are not obliged to perform RSI on a pediatric patient unless the RSI paramedic feels comfortable with the situation to proceed. So if we compare the Suffolk County protocol to the collaborative, we don't require a GCS less than 8. The last 25 successful RSIs in Suffolk County noted that 11 out of 25 had a GCS greater than 8, which is 44%. We also only allow for 2 attempts at endotracheal tube placement by the RSI medic before placing a supraglottic airway. And we actually state that in the protocol, which is a little different than the collaborative, which allows 3 attempts maximum and then consider it an insertion of an alternate airway device. So we just phrase it differently. 2 shots, no success, place king airway or a supraglottic airway, move along. That happens about 10% of the time. We also do not have a second rescue or assist with laryngeal manipulation. Since most of these are being done with the bougie and a video laryngoscope, it's actually not indicated. And many of the medics would find it harmful and in their way to have another person in the way, so to speak. So I would remove that. We also use fentanyl as a consideration in pre-treatment in neuro cases. And this was brought in by several of our neurology experts that we've involved in stroke and neuro cases. That's all I have. That should be the end of all the slides. Feel free to share the RSI protocol that we have, look at it, pull it apart, and feel free to ask me questions. But one thing that I've found that multiple step process needs to be in place because it allows several areas to catch a problem and several areas to re-educate a medic as they learn this new skill set. Several of our paramedics only do this once a year. We do have medics in the program that have more than 100 field RSIs since the program began. Actually, we have 3 of the original medics still in the system. Each one of them has been doing it now for 10 years, and they're kind of the outlier. And now we use them as educators in our training. So ask me questions if anyone has any.
I do.
Yep.
First of all, I want to thank you for sharing your protocol and an excellent talk. Most of our agencies don't use video here, am I correct? So do you have any idea of what percentage of the intubations RSI there were used with the video versus non-video?
Yeah, so up until about 5 years ago, nobody had it. And then 2 agencies got one and really liked it. And then they started telling their friends and telling their friends. And now approximately 75% of the intubations are done by video. And I will also tell you, some agencies, and we leave it at the agency of discretion, make it required that they use the video before they are allowed to perform the procedure. And they use direct laryngoscopy as their backup. It started the other way around. We wanted them to have the video laryngoscope in the bus in their bag of tricks in case they had a problem, they could at least look, and they have switched. We also don't require the use of a bougie. Some agencies have. I like a bougie, especially for that mucky airway, pukey airway, bloody airway. Most of them use the King Vision as the actual choice of the laryngoscope they use.
As a follow-up to that, did you see a difference once they started using the video in your statistics of successful intubations?
The trick is it requires a skill set that's different than direct manipulation. As you know, direct laryngoscopy involves, as much tilting as you can and as much leverage as you can, whereas the video literally is a scoop. So it's a different skill set. We find the younger, I'm 53, the older medics like us, we like the old way and we learned that way. The younger ones coming just out now like the new way, which is video. So it really has separated our forces into old and new. I will tell you that many of our skilled paramedics still do it the old-fashioned way, but they've done it for so many years that we don't challenge them on that. And most of the new providers who are coming up learn with the video and like it more. I will tell you that's an agency medical director choice. Most of the agency medical directors, it's the same thing. They're ER physicians who work in ERs where they're told they have to use a video, so they use it in the field. I would say that the numbers are hard to give you, but our success rate has always been very good. It's hard to split hairs, but it went up slightly. The last missed intubation we had was actually with a video laryngoscope. It was a patient that they thought they saw the right thing, and we could see on the video when they downloaded it, it was in the wrong place, and that's how it was caught.
And what hospital do you work in?
After 22 years, last year I retired. I worked at Good Samaritan Hospital in Long Island.
Now you don't do any more ER work?
No, I work for the county full-time now.
Okay.
We are lucky in Suffolk. We have a full-time medical director.
I agree. I was a bit skeptical in the past, but I think your presentation was great, and the way that it's done in the QI, it certainly sounds feasible and safe. And I think as far for the paramedics, it's it would offer some satisfaction, I think, too, and advancement and some career satisfaction. And so I think there's lots of benefits.
Yeah, we're weird in that we have 104 different agencies. So we picked and chose the right agencies to start with. If you have a similar model where you are, or is it a one large system under a commercial, you would definitely want to select the highest end paramedics to begin this with, get the process rolling so you get used to it. So it depends on the system that you work in, but you definitely want to set yourself up for success. So you want to choose and hand pick the persons that you select.
Right.
We didn't allow for the first 5 years anyone in the system to do this that we didn't know was going to have a very good success. So you don't put it for the bottom denominator like other protocols. You actually set it for the highest denominator.
Sure.
If you get my meaning.
I have a question, and that's out of the successful intubations, how many actually needed to be repositioned, i.e. did it go down the right main stem? Did it have to be pulled back?
That's on the
Yeah.
audit form too. And for some reason, no one ever says anything. So I assume that there must be one that they're just not documenting, but that's the audit form, as it says, did they need to reposition the tube? Was it right main stem or not? And I can't remember the last time I read them all. I can't remember the last time I saw one. And I'm not sure if they're just not writing it, or maybe it was that point at which the physician decided not to write it, but they educated the provider. Hey, your tube was great. I want to give you full success for it. It's a centimeter too deep. We'll just pull it back. That's not being captured, but I will tell you that since most of it's on video, you could actually record it and see. So in about 75% of the tubes, you'll be able to see where you are. They actually download it and keep copies. We allow it at the agency level. I don't keep the copies in the office. I let each agency do that. Any other questions before I have to run?
Oh, I want to thank you very much for coming on, but anyone else?
Do you have a process for, is there a process for removing someone from the RSI program?
So the reason we have such a robust quality improvement process is at any place along that line, someone can be removed by either the agency medical director, the medical control operator, if they find it was a missed intubation. Like if it's a missed esophageal intubation, our policy is the medic is removed from the system until they're re-educated and the case is investigated. It prevents there from being more than one case in a row. We haven't had it happen in 5 years, but it did happen some years ago. We haven't removed an RSI medic for a missed esophageal intubation. What we have done is remove medics for lack of participation in the annual skills training requirement. So we had some medics who just didn't want to do the training and we took them out of the system. We're lucky in that our medical control operators work for Stony Brook University Hospital, but they work as an extension of the county. So I control medical control myself. I can just call, let medical control know medic XYZ is no longer RSI credentialed in the system, and it goes immediately.
So it's any position in the process can either suspend or remove. It's the emergency room physician, it's the agency medical director, or the regional medical director.
Right. And what usually happens if there's a real problem, the ER physician usually calls our office and we handle it. But again, it hasn't happened in so many years. The earlier years when you start, if we found that there was a missed intubation, we would take the medic out for 2 weeks, bring them back to the division, do their training all over again, like they would start from scratch. Take the high fidelity mannequin, show us how to do the procedure. Here's the exam, take it again, just to re-educate completely. But that was 10 years ago. We haven't had a problem in the system, as I said, in more than 5 years because they get really good at it. And that's what's amazing. We selected the best medics to do this with, and they're highly successful for that. They take great pride in it, and they train on it at their own agency, and they love it.
Thank you.
Thank you.
If anyone else had any questions that didn't get to share, feel free to email me. I'll put my email in the chat.
Thank you very much. Appreciate it.
Yep, glad to help if I can.
All right. So I think with Dr. Sheriff being back on, that brings us to 6, which would give us over 50% of our voting members present. Mike mailed out the minutes for last meeting. Anyone going to take a chance to take a look at them? Motion to approve from anyone?
Motion.
I make the motion. I'll second it.
All in favor? Aye.
All right.
Anyone opposed? Good, motion carries. We'll move on to some of the old business. Thankfully, Dr. Winslow was there to talk to us, and if anyone has any further questions, feel free to email him. I like what he had to say for it. It helped break my skepticism. If anyone still has some skepticism, I'd really love to hear from you about it. I definitely do have concerns, and I think it shows the robust amount of work it goes into it, but also the high quality that it can have if present. The STREMAC policies, I think if at next meeting, if we haven't heard from everybody about it, I think at this point we've heard about it more than enough. So if not, I think at the next meeting, we will just redivide all of the policies and make sure that we have them all out there just so that we can have an update of our policies. It's been about 2 years since we announced it, and we've gotten a couple of them reviewed. I did send an email out about a year ago just saying what everyone's policies were to review. If you need me to send it out again, just let me know. But at the next meeting, if we haven't heard back from a substantial number of people, I think we'll just redivide them and start from the beginning again. Mike, what about the med control certifications?
We probably could use roster from each of the hospitals for verification. Because we're kind of getting them in one-offs. I know there's been a little bit of churning in some of the ERs. Congratulations, Dr. Bohan, by the way, taking over the ARNIC.
Yep.
So it'd probably be helpful if we restarted that again.
Okay. So we can send out an email to James, Beth, and I'm not sure who runs Skylar at this time, but we can look into that.
And Ira and St. James. And St. James has new leadership too, I believe.
Oh, St. James does too? Yeah, I have the email for Ira. I can get him too, just to check on that.
Is it worth bringing the residents into the credentialing program for medical control? I know at least when we go to the ARNIT, we're speaking with the residents very often. I don't know if they need to be brought into the credentialing program. I know they're all overseen by attendings, but.
The residents do take the test. The reason why we haven't put them through so far is because they don't have their own license. They're under the license of the doctor they're working with. Every year, the interns take the very long 50-question test that we made a while back. We can get their names because every year we do put them through the protocol exam.
In addition, when EMS asks for medical control, it goes to an attending.
Yeah.
Let me know if that's not happening, but every time I've worked, that's the case. So.
Yeah, I mean, I'm not there in the ER anymore, but it would seem to me that you would want, when they get to be third-year residents, that this would be a good step for them to take, get a license and be credentialed to do that. Because I just think it would be a good thing for them to do. I'm not, like I said, I'm not there anymore, so James, you have to decide.
I can speak from the field. There's a high level of trust, at least with the third-year residents, when speaking with medical control. And if I do get a doctor on when I'm calling for medical control, and I do get a resident, but I feel like I need something above that resident, I always ask for an attending. So I mean, but there is a high level of confidence with the majority of the residents.
Yeah. I know the last few years, it's been 3 years and us, I've been a faculty member. Every year we do sit them all for the protocol exam. So we can give you a list of the roster of them. But with them, I don't think any of our residents right now, with the exception of maybe one of them, has a New York license. So I think for anything that would require medical control, even if the resident's available, I still would opt for the attending physician, as you were mentioning, Rick.
I mean, generally what would happen is they'll be at the radio, but I know my ears perked up when they said they're
Yeah.
control, and then I was just listening into the conversation. And then they would use my name.
Well, also since we have Vocera now, it's a lot easier to find us. Any update on EMS or ED delay times? I don't know about the other facilities. I know ARNIT, we try to get them off the stretcher as soon as possible. One, because we don't have the space to keep them in our hallway, and two, because we need you out in service. Anything from EMS?
Any agency outside this region?
Is in comparison with hospitals outside our region is extremely good at getting ambulances turned around. I would have no complaints other than the occasional outlier, but those can all be explained by what the circumstances are in the ER at the time. So
The state is still putting out the reports every 4 hours or whatever the case is for diversions. And it's typically been upstate for the most part, an occasional Wilson. And that's pretty much the closest that it's gotten to here.
I would say there's no issue that I've identified
Excellent.
within our region. So
Good. All right, excellent. Brendan there for anything, any kind of updates, or did he leave any for you, Mike?
Brandon is doing ACLS for Lecon this afternoon, all day today, tomorrow, and the next day. They did graduate the last paramedic class. They did their graduation, and the current class is ongoing. The 2 EMT classes that we're going are finishing up probably the next week, 2 weeks, Bruce.
Yeah.
So they should be
testing out the end of February.
Yeah, they'll be testing out the end of February. We tried to put up a CFR class and we got very low enrollment, so that probably is not going to fly. There is a refresher program that's going to go on at Big Flats Fire Department. That will fly. And I believe that AMR may be doing their boot camp where they're going to do the crash course. They're employed by AMR, and I guess they're going to take 2 weeks and run everybody through the EMT program. If they come out the other end, they'll be fully credentialed providers with AMR. Also, I believe there's going to be an EMT class at Monterey Fire Department. I don't know if that's going to fly. We just got their information today. So other than that, there's not a whole lot of lower level education going on in the region this semester. But they will start up again in August.
Sounds good to me. I see Brian on there. Brian, would you like to give us DOH CMAC report?
Good afternoon. Really, it's been busy with COVID deployment stuff, national ambulance contract, trying to do surge operations and stuff like that. I really have been between Syracuse, New York City, and all points east and west, not really around doing program agency stuff. I'm trying to think if there's anything else that's coming up. I know that starting this weekend, we are cutting back the 50 NAC ambulances that are in New York City. They will no longer be there. So it's just going to be the 60 or 50 units that are Albany, Westchester, Batavia, and Syracuse.
Okay.
That's about it. Any questions?
Do you know when that national ambulance contract sunsets?
So they are in the process of extending it. Currently for the upstate units, I believe the extension, and don't quote me on this because they haven't told us, is pending. We're still not sure on the number that they're gonna extend for and for the amount of time. I think they requested another 30-day extension, which would start, I think, sometime this week, but they weren't sure if they were going to get 30 or 15.
Were they well used?
Yes. The New York City numbers helped. They hold on. There we go.
Just curious how beneficial they were. I know they came down into our area and helped us out a few times, and it was very, very much appreciated.
I don't think we've needed them a ton, but the times we've needed them, they've been a huge help.
Absolutely.
So I don't have, I had written somewhere, but not for this meeting. At one point in time, they had been deployed into over 7 911 systems in different counties. Erie, Niagara, Monroe, Westchester, and a couple others that I can't remember off the top of my head, as well as doing the interfacility transport and other work. So, yeah, I mean, they got used a decent amount.
Good.
Any other questions? I think they were a great resource when available, especially when we were a little short-staffed or other places were a little short-staffed. They came and helped get people where they needed to be. So it was great to have them. All right, Mike, you want to give the pad and the agency updates? I just got the email from you about it.
Yep, PAD renewals, Hilton Garden Inn, Dr. Rizone, dentist, Parish of the Most Holy Name of Jesus, St. Casper's Church, St. Patrick's Church, Village of Odessa, Watson Homestead, and Wyckoff Gas, all completed their renewals. BLSFR renewals, West Del Mar Fire Department, Bath VA, Fire Department, and Corning Joint Fire District. Ambulance renewals, Tuscarora and Woodhall. They also submitted their paperwork and was acknowledged by the state.
So they need anything from us or no?
No, nothing's new, so they need no approvals. These are just informational purposes.
Yeah. It looks like it's just informational, so. All right. The next thing on the agenda is the New York Matters program. This is something that's being run through Buffalo. For right now, it's hospital-based, but it looks like they're also going to be trying to extend it out into EMS as well. This is for addiction medicine, most notably opioid use. It's for people that are either in acute withdrawal or they had to get Narcan, they had to get something else. What it starts off with is if the patient calls for withdrawal, they can be brought to a place that they can be seen. Right now, Arnett is involved in the program, and essentially they're going to be treated in the emergency room and given an iPad. The iPad will help them gauge their level of interest and also help them schedule their first appointment. Once they get their first appointment, it will also print out a voucher for them. 2 different vouchers. One is a voucher for up to 2 weeks worth of medicine where it'll be covered for no additional cost to the patient. Their insurance will cover it. And the other voucher is for transportation to and from their first appointment. Ultimately, it looks like New York State at the last STREMAC meeting, they're starting to develop a protocol for treatment of opioid withdrawal in the field, not just in the hospital. These aren't for patients that just woke up. These are for patients that have been in withdrawal for quite some time. And rather than wait until they use again and have to treat them with Narcan, you'd be able to give them buprenorphine or Suboxone in the field. New York State looks like it's heavily starting to push in favor of that. But right now out of Buffalo, they're starting with this NY Matters program. If agencies are interested, they do have little components that are for EMS agencies. Ultimately, you can get the same iPad that the hospitals are getting and try to refer patients so that they don't have to call, they don't use again, or they don't end up as, you know, your second or third Narcan wake up. The other benefit of it is sometimes the insurance companies will only pay for one injector of the Narcan. If you go on a call and the person has already used their Narcan and they can't necessarily afford another one, by using this program, they can print out a voucher for the Narcan as well. So there's a lot of utility with it for agencies that want to get on board with it, especially to help serve a patient population that doesn't always have their own best interests in mind. I know Kathleen had some interest in addiction medicine patients. My own interest, I think, as most of you guys well know of it. But if any agencies are interested, it's something different you can do rather than just going on the Narcan wake up and either transporting them to the hospital or having them sign off. This would be something in between where they can get access to medicine, they can get access to treatment. And I know it is frustrating for a lot of the crews to go to the same person over and over again and not have anything else to offer for them.
How do they then get referred to the, you know, providers who are doing Suboxone? Because I thought New York State took off the waiver requirement even now that you just have to.
So, New York State looks like they're in the process. I haven't seen anything official that it is completely gone. With the iPad, any agencies, like if Casa Trinity or if Helio or somebody else is affiliated with the program, they can actually pick on that iPad the location where they want to go and the time slot that they want to go.
Oh.
So they'll pick a location and a time, and that will help print out their voucher for the transportation.
Okay, because in Corning, I think there are only a few of us that do it. Like Pete Parkin and I are the only two at Guthrie.
Yeah, we're in a region where there's not a lot of people who either have the X waiver, and there's even less people that are addiction certified. So I think there's only a handful of people that are board certified in addiction medicine in the entire region. So it's tough to find slots for them. That's why this is supposed to help make it easier. On that iPad, on the program, they can actually pick the location, the time slot, and the day that they want to follow up.
So, but I bet Pete and I don't show up on that.
If you get involved in the New York Matters program, if you contact them and say you're interested in receiving those patients,
yeah,
they will add you to the roster.
Okay. Okay.
That's why through ARNet, we've agreed to take part in it. The program is still in its infancy. I think right now they only have a couple of hospitals and a couple of regions they're involved with. They have some by Albany, some by Syracuse, some by Buffalo, and now in Elmira through ARNet. For us, it's also a great resource because that tablet on that iPad, the person can make their own appointments. They can get their own referral for treatment. And they can also print out for whatever medication they're going to be receiving, they can print out a voucher.
Who decides the dose that they get, like from that, like?
So that would have to be determined by a doctor. If medication is prescribed, they can print out the voucher for the medication.
I see. Okay.
And as far as the EMS component, looking forward, there is on the protocol that's being developed a portion where you would contact a New York Matters doctor. Right now that's done through Buffalo. So the New York Matters doctor could help determine the rest of it for the agencies.
Okay. Yeah, I just recently I've seen, you know, so many ER like bounce backs of some of these, particularly meth, unfortunately. Like I've had a bunch of people who are, you know, you can get them off opiates, but by God, you can't get them off meth. And these people are going in with delusional behavior. And I guess I'm so old, right, that I remember the days when we 2PC people and, you know.
Unfortunately, they won't 2PC anyone for drug-induced or substance-induced mood disorders at this time. The treatment is just to wait for the mood disorder to clear, because ultimately doing something like that is restricting somebody's rights. So they have to pose an imminent danger to themselves and others when clinically sober in order for us to be able to do that.
Right.
And unfortunately,
when they have like young children, then they're picking their skin off themselves. It's just like, why can't we get them help?
Well, unfortunately, as you're mentioning, meth is the one that there is not medication for. It's just counseling. Counseling doesn't work rapidly. And it's a lot of instant gratification that people are looking for. But this would help set them up. And it looks like they plan on starting with opioids and then going from there. The only reason being is the one that we've seen far too many of our young brethren die off from is opioid use.
And Rob, you said there's a voucher for 2 weeks of medicine.
Yes.
You're not talking about Suboxone, though, are you? I mean,
if you want there to be Suboxone, you can prescribe Suboxone. The voucher would affect whatever medications are prescribed for the patient. It's similar to what we're doing in ARNet as it is now. It's just giving them further resources. It kind of doesn't break away from the ARNet program that Frank and I started a couple years back, where we would see them, we'd break them out of withdrawal. And if you have an X waiver, you could send them home with medication. If you don't have an X waiver, you just set them home with their earliest appointment available.
yeah, and we would have to come back, get the up to 3 days in a row.
Yeah.
Get a dose of Suboxone, but not give them 2 weeks worth.
That wouldn't change unless you as the prescriber are comfortable with that. If you're not comfortable with that, you just give them the iPad, you give them the medication in the ER, you have them make their appointment. If you're comfortable, I often send people home with a couple days worth, mostly because when I work, I tend to work in stretches of 3 or 4 days. And while I don't mind seeing the person again, if I can treat them at home, I'm more than comfortable doing that. But if you as the provider are not comfortable with that, You can treat them in the ER, give them the iPad, they can refer themselves to treatment. This way, it cuts out some of the steps and cuts out some of the work that we used to have to do by having them fill out all those papers and fax them over. We're trying to simplify things rather than complicate things for some of the places, especially for our critical access hospitals like IRA, where they don't have access to social workers all the time, where they don't have access to people. This way, the iPad can help them out with it. But that's the NY Matters program. If any of the local doctors who are actually prescribing medications in their office are interested in receiving some of these patients, you can fill out on NY Matters to make yourself a referral site for the patients as well. And again, there is going to be the protocol coming down through New York State. So I wanted to make sure everyone was at least familiar with it and where it's being driven from.
Hey, Rob, I have a quick question. If you're treating people from home, how are you covered for malpractice insurance?
So that's what the part they're still working on. It's part of the protocol eventually that hasn't been finalized. I know a lot of our agencies in the state, not so much in our region, but a lot of the agencies are starting to move towards like telehealth on the ambulance. I don't know if any in our, I don't know about AMR, but I haven't heard anything from Airways. I know out in Allegheny County, they actually have telehealth that they'll bring to people. And for minor complaints or RMAs, they will have the doctor speak to them. So they have the capabilities to have a face-to-face evaluation with somebody who's being covered by malpractice insurance. I don't know when this reaches its final stage, what it's going to look like. It's still in its infancy. However, the protocol did get approved in its infancy at the last CMAC meeting.
Good.
Maybe at the next meeting, I'll be able to give more for that, Dr. Sheriff, but for right now, it's still kind of early on. Any other questions on the NY Matters program? And I will make sure that I email out to everybody the link for it so you can look at it yourself and see what you think about it. I think for research ideas, we keep trying to come up with something. I think Dr. Berry is as close to anyone as getting some research off the ground. But if anyone else has anything that they want to bring up or any ideas, we're always willing to hear about them.
I don't have much going on at the moment.
All right. Otherwise, Rick, you have the floor about the SCT course.
Yes, we have a number of providers that we want to send to the SCT course where we have the slots available to send to the University of Maryland program, but there's another 3 or 5 that we'd like to go just because of personnel level, staffing levels. We're not able to send them to that. So we'd like to send them to the flight paramedic program, which is a bridge program. And I'm sure Sean can speak to the flight paramedic program that it's essentially meets the same standards as the University of Maryland program. And we just like the doctors here. We just want to get the blessing from the doctors or at least hear from the doctors that these paramedics that we send to the flight paramedic program will still be able to do critical care skills for the interfacility transfers, which is the ventilator and the out of general scope medications.
So this is basically to expand the certification of current paramedics to an equivalent training of the paramedic CC for interfacility transports.
And instead of being a CC EMTP, they'd be a FP EMTP.
Okay.
And I'm sure Sean, I'm sure went through the flight paramedic class and he can speak to the curriculum on that. And I'm glad you're here today, Sean.
Hi, everybody. Yeah, I can speak to that a little bit. FPC is what we require with Air Method for CAMES accreditation across the country. FPC is recognized it will definitely fulfill what it is, the continuity that you're looking for. And the only thing it's going to add a little bit more of the flight considerations. And honestly, that would be great for your ground paramedics also, because if for some reason that we're to transition to flight, they can make those decisions at the ground level as well. So I highly support that. That is great for the area. That is fantastic training. Would really support that and encourage that for the region.
It would give the ability to add seven more paramedics in our region to be able to do out of scope interfacility transports.
And I guess a question that Brian might be able to answer, would they have the same scope and the same level of responsibility on a statewide, just for protocol reasons?
Is that a question to me?
For either you or Brian, I'm not sure who could answer it, to make sure that they'll meet the same level of training, and the state will recognize it as equivalent.
And testing my understanding, you just want to make sure there's that continuity across the state level.
Correct.
Yeah, well, we're under we also are under the Remo version. I know Bryce is on as well, and we continually check those continuities, and Remo also works very closely underneath New York State. So yes.
Okay.
Sorry, guys, this is Bryce. I'd say, Brian, you can attest to that, but that's my understanding as well. As far as at the agency level, it's commensurate.
Correct. I would agree.
Works for me. Anything that increases the ability of the medics in our region to be able to participate in high level care, I'd be all for it. Anybody else have any questions or any comments for our friends about the SCT?
I've taken a few of I took the review course before they take the exam, not just the course, there's some review classes as well. They're excellent. They give you great literature to look at and study from. So I can't speak to the other courses as much, but I know that's high caliber as well.
I think it's along the same lines as the University of Maryland program.
Yeah, all right. Do you need an endorsement from us, Rick?
Just your word that it will be accepted at the same level as the SCT, so that we're not sending these people to this class and coming back and saying they cannot perform at that level.
Does anybody present of our voting members have any objections to the medics in our region taking this other class instead? Which I think
No.
will be great for our region to have higher level of training among our providers.
Great idea.
All right. If all are in favor, I'm in favor. All right. You have our blessing, Rick, and thank you for helping to pursue care in the region.
Thank you.
I have nothing else on my agenda unless somebody else would like to bring something else up. Our next meeting would be May 4th.
I'll make the motion then.
I'll second.
Very good.
Thank you, everybody. Have a good
Okay.
couple months. I'll see you in May.
Thank you.
Everybody be safe with the weather.
Bye.
So what precipitated Jeremy leaving the chairmanship? Is it his decision or their decision or?
No, it is.
He was that around. Yeah, I mean, so you know that's not.
If you turn off the recording, Mike, I can speak more on that, Mark.
I'm trying to get.
I'd like to hear what you have to say. Rob, what do you want me to do?
You had to stop, Mike, right to the right of it. There you